Hey, we're getting there.
All right, we're live.
Okay.
Sorry for the delay,
If that
everybody.
works. All right. So, can you guys see us and hear us? Okay, one of you guys still has your YouTube, or is it me? If you got the YouTube up, make sure you mute it. Yes, yes, yes. Okay, perfect. All right. Excellent. All right, sorry about that, everybody. It's like our first time or something, right? Dr. Smith, how are you today?
Doing well. How are y'all?
Okay. Dr. Nassar was here a minute ago. I'm not sure where she went, but she'll join us back. Dr. Smith, I believe you're looking for a University of South Florida emblem there, not an AU.
Got to go with my my original love.
All right. Oh my God, there was knock jokes in the comments while we were waiting. Brutal.
See how good they were.
Wow. Okay, so that's pretty fantastic. All right, Jasmine, any updates for them before we get started in terms of training?
Not off the top of my head. We're working on PHTLS stuff over here today.
Okay. Sounds good. You got my light board ready yet? I'm supposed to record a lecture on that before the end of the week.
Oh yeah, not by the end of the week. For
Come
sure.
on. It's for ClinCon. Okay, so it looks like we've got a good number of folks on, so let's go ahead and get started on the updates. Unless you have anything else, Jasmine? No?
No, I'm good for now. I'll jump in if I
Okay.
think of anything.
Sounds good. All right, I'm going to start sharing some screens.
That was a good knock-knock joke.
It was a good knock-knock joke. All right, here you go. Almost 12,000 cases, 262 deaths in Pinellas alone. That doesn't even include all of Tampa Bay. That's a mortality rate of about 2% of diagnosed cases. Obviously, the real number of cases is probably more than that, given that we still haven't tested everybody. But certainly, you've all seen in the news that our numbers are not looking great, to say the least. Here is the Pinellas rollings. So you can see yesterday was our second highest day with 598 confirmed positives in the county. And you can see that our hospitals are having more and more patients in them, fewer and fewer available beds. Here's a one for you. Let me get it back here. Sorry, let me just find the thing I'm looking for. Here we go. So here's a weekly surveillance report from the County Department of Health. I am seeing a little bit decrease maybe in the ER volumes, particularly of non-COVID patients. So I think that maybe reflects a little bit of where we were previously with folks being kind of scared to go to the hospital. We are seeing, the reason I wanted to show this is this down here, which is very, very scary. All-cause mortality this past week was 37% above what it was the same week last year. And it's been high for the last couple of weeks. And so that really scares me in terms of what are the effects of COVID in the community beyond just diagnosed COVID cases. Not a super encouraging kind of deal. There are over 100 people in the Pinellas County ICUs being treated for COVID right now, and nearly half of them, about 50 of them, are on ventilators, which is a higher number than we would like. Altogether, there's 450 plus patients hospitalized in Pinellas County with COVID, and our daily numbers are pretty stark in terms of the total numbers. Edgar says I need a new light board guy. I think I would have to agree with that. I mean, Mark said he was going to build it, and I don't see any light board. So, um, I think one thing perspective-wise to bear in mind is that in the peak of New York City's experience this past spring, they were diagnosing somewhere in the neighborhood of 10 or 11,000 cases a day for the city. We in the state of Florida are now running 11 to 15,000 cases a day. For perspective, if that continues, we're going to look like New York City in a very short period of time with all of the things that they experienced. We, and I think all of you watching this know, we're tired. This has been a long road, and we're tired. The hospital staffs are tired. And there's no end in sight. So I think there's some hard decisions for us as a community coming up here. And what I would ask of all of you is that you don't let your guard down, even though you're tired, and you do whatever you can do on and off duty to slow the spread. And I don't really care what anybody's personal political leanings are. And I have no idea how this thing became as politicized as it is. But the fact of the matter is there is widespread, like forest fire, widespread transmission of this virus in our community right now. And we all have a responsibility to try to slow that down. Even if you don't think that you could become severely ill from this, it is quite clear that we've extended this to other segments of our society, and that there is no way that one segment of society can get it and not have some spillover into others. So please, please think about that both on and off duty. We've had dozens and dozens of system responders infected now, and most of those, all of them, have been largely off duty, and some inside buildings while at work. Thankfully, we don't believe we've had any still patient exposures that have gotten us sick, but a lot of those have come from people's activities off duty, and we just need to model good behavior to the community. Whether that's wearing your mask or socially distancing or choosing to skip an indoor space where there's multiple people there that you don't have to be in, whatever you can do, whatever's within your own personal realm of interventions to make to slow a spread, I would strongly encourage and beg you to do. This is a bad situation for us as the community. I know nobody wants to talk about a lockdown again. We are far beyond any measure that was proposed for when it's okay to undo the lockdown that we previously had. We've blown by every one of those measures. Whether you look at the Harvard Global Health Initiative or the White House plan for reopening, we've blown all those out of the water. And there is just no way that this thing slows down unless we take a little bit more aggressive action. And you all know as well as I do how strained the hospitals are, how strained we are, how strained the community as a whole is. So, I'm very sorry that this has become as politicized as it has, but whatever you can do personally to model good behavior, to talk to the folks that look to you for medical advice about where we are and what's going on with this thing, I would encourage you to do that. A couple of pathophysiologic updates. There's been a lot recently about antibodies not lasting too long. I don't think that necessarily. I don't think that necessarily means that there's no protective effect long term, but I don't know that we know that for sure yet. I think that vaccines are hope, but hope is not a strategy. Hope is not something that you want to rely on for salvation at this point. I am seeing progress in terms of treating with remdesivir, although remdesivir is on shortage now. We're seeing some new medications with potential promise. So hopefully we get the ability to slow down the damage based on those. We talked last time about prolonged illness after, even for young and healthy people. And there was one study that showed 60 days after diagnosis, 50% of people still had severe fatigue. And something like 25 of them still had shortness of breath. And something like 20% of them still had myalgias, crampiness, and chest pain. And I don't know if you guys heard this story from the doctor over in Texas where they had that COVID party that all those kids went to. But she was in an interview and she said the dying words of this college kid were, "I think I made a mistake. I thought it was a hoax and I was wrong." So we have had multiple people die that are otherwise young, healthy people. We've got all sorts of disease going on in the community. You see the impact on your staffing, cross-covering shifts. You see what it looks like in the hospital. You see what our mortality rate looks like. You see how many people are in an ICU right now. All of the things that we said we wanted to avoid with the shutdown. And I don't see us headed in the right direction. Every metric I see shows us going in completely the wrong direction. So what I would say to you all is please do whatever you can do to be part of the solution and not part of the problem. I don't know whether there'll be the political will to take more unilateral or broad steps, like other places are starting to do. But either way, I think it's very clear that we are not in a good situation right now. In fact, the maybe one of the more inflammatory headlines I saw recently was that right now Florida ranks only behind 3 countries in terms of the most number of cases. So the state of Florida has more cases than all but 3 countries. What does that tell you? We're not doing a very good job. So there's a few other technical things, like for example, a mutation that has affected how contagious the virus is, and a lot of discussion on droplet versus airborne. So I'll get into that in a second, but I'm gonna answer this text real quick. Dr. Smith or Dr. Nassar, do you have anything to add?
Let's say the only other thing is just like it's wearing on all of us, it seems to be wearing on members of the community as well. I know anecdotally, my last 2 shifts in the ER, I saw more violent crime than I have in the past 3 months. So it's affecting everybody as well. So just be aware that people are getting antsy and irritable in the community. Like I said, I had more gunshots and stabbings over this weekend than I did in the past 3 or 4 months. One night I had 2 gunshots and a stabbing alone. There's a total of 5 gunshots and 3 stabbings. So be aware of that when you go out. That the people we serve are going to be very antsy.
Okay, sorry. Yeah, and actually that's on the discussion on the Eagles this morning. They're seeing that all across the country where there's just huge increases in penetrating trauma. So there's a significant comorbidity from what this virus is doing to our country, whether it's the fact that we've got 10 or 15% more out of hospital cardiac arrest than we normally do, or whether it's the fact that we're seeing shootings and stabbings and all that stuff go up. There's some serious disturbance and morbidity and mortality in the community. And I would echo you, Dr. Smith. Kindness right now is probably what our community is lacking the most. little bit of human kindness here. This is one of those times where we really need to come together as a system, as a community, as medical professionals who folks look to. So whatever you all can do to answer that call, I think would be really beneficial to our community right now. All right, there's been a mutation in the virus. The mutation is a single amino acid that has made a little swap, and it's the D615G mutation. And we've gone from about 50% of the cases in Florida having that a few months ago to now pretty much all cases in Florida have that. There was an article published on this recently, and basically it comes from work done by Los Alamos National Laboratory. And what it really comes down to at the end is that the mutation has allowed the virus to more readily enter the cells. It's a mutation to the spike protein, which is the protein on the outside of the virus that attaches itself to the ACE receptor on your cell and therefore allows the virus to enter the cell. So it seems to make that happen more. It also seems to make your cells make more copies of the virus. So viral loads tend to be higher, which means that people shed more virus, which means that the virus is potentially more contagious. So that may be part of what we're seeing in terms of the numbers skyrocketing. Unfortunately, there is no evidence that that mutation has changed how dangerous or how sick people get from the virus. So we don't have any evidence that there's a change there yet. But you certainly have probably heard stuff about the two different types of viruses or mutations, and that is true. And if you want to learn more about that, you can go to, here, I'll copy and paste a website in here and you guys can look at it. Okay. Yeah. Jasmine said it's a good time for PHTLS with all that penetrating trauma, huh? Unfortunately. Okay, yeah, I have seen a few more, maybe SIM code H's recently, and violent kinds of scenes and stuff. So yeah, please be careful. Okay, let's open it up to questions now. Go ahead and fire away.
And go. It's been pretty silent, pretty quiet in the chat today.
Yeah, I know. They're got anything? Here, I'll put on some music for Peggy in the meantime. This is just the latest royalty-free thing on YouTube. There you go, Peggy. Perfect. Come on, somebody's got a question. Otherwise, we'll just hang up.
I'll start talking about CME. I know that's everyone's favorite thing. No questions. CME talk is coming.
Okay, here we go. Getting a couple. All right, so how has the potential 14-day delay for testing results impacted us? Well, it's impacted us in terms of getting people back to work, and it's impacted us in terms of knowing when somebody's positive that you have to do a quarantine after you've been exposed to. So it makes everything a lot more difficult. And I know they're working on it, but we don't have a great answer yet. So yeah, Troy, it makes everything more difficult to not have rapid testing. Jasmine, what are you doing? You keep like flipping back. Mute yourself or something. There you go. Another one says, do you want to chat about the Hep C drug potential? Yeah, throw up the Medscape link, Jeremy, if you'd like. There's a hepatitis C drug that's used a lot in Europe that is showing some good in vitro, meaning in a test tube kind of activity. It means basically hepatitis C is the structure of hepatitis C is a somewhat similar structure, like the mechanics of how the virus works to COVID. And this hepatitis C drug is showing some initial promise. I wouldn't hold my breath on it yet. It's still got a long way to go before that's something that will probably be at patients' sides. But yeah, if you have that link, that would be great, Jeremy. Chief Bessler said, clinicians testing update. Well, no response from the FDA yet on our submitted validation study. I do know that LifeScan is now offering services for those of you who use LifeScan. I think they're charging quite a lot for it, but that is an option. I don't have the specifics. Well, I know which test they're using, I think, but I don't have a final read on just how much I trust that particular test. I don't have a great update for you. We're still working on it. There are more tests available. Whatever we do in terms of a test has to be in partnership with a lab, though, since none of these are EUA waived or CLIA waived type tests. So I'm still working on it. I haven't given up. It looks like we may get our $60,000 that we already spent on the other one that got pulled away back. So that's good. But I don't have a great answer for you, Chief Bessler. Troy, so does that give us a reason to not get tested if symptoms are mild? No, no. You want to know if you have this for the sheer sake of being able to not spread it to other people. And so we also want to know if you have this so that we understand how the virus is spreading through the community. So if you have symptoms, you should get tested for sure. Yeah, and obviously keep isolating. Yes. Do not come to work while you're waiting for your test result. Do not come to work when you're not feeling well. Stay away from your family and friends and all that other stuff. This is what I was talking about making sure that we're modeling good behavior to the rest of the community. Okay, Handoga says, not necessarily COVID related, but on the topic of scene safety, do you see any changes to EMS responses in response to the St. Pete policy of not sending LEO to certain types of calls? So I think that discussion is ongoing. And I know that there's been specific discussion on that. I don't know the answer to that yet. It's something we are looking at, and I really don't know the answer to that yet. Handoga, I think it remains to be seen how that gets fully operationalized, but it is something that we're concerned about and that we're looking at. Peggy says, regarding working codes in nursing homes, do we still work them where they are or transport? Last call we transported, but I was not sure why if something changed. So again, I just refer you right to the category yellow, suspected COVID placard, and that should be what we're following. That's the only difference from normal treatment protocols. And in general, normal treatment protocols are still in place with the addition of those considerations on the yellow card. So no, nothing has changed regarding that, Peggy. Billy says, with all the stress on our crew, just remind them of the behavioral health resources found on Target Solutions. I can't emphasize that enough. That's a great point. This is tough stuff we're dealing with here. This is historic, really, hopefully once in a lifetime stuff. None of us wants to ever do this again. And the toll it takes on all of us is huge. And I know, when you strap on your PPE and you go face to face with somebody that you have a pretty high suspicion of, or, in my case in the hospital, sometimes I know for sure that they're positive. That takes guts, and that takes fortitude, and that takes a certain level of person to feel like it's part of their job or duty or calling to care for people in that manner. And it is not without stress, and it is not without um, uh, difficulty. And we know that healthcare providers are among the most affected of any segment of society by this virus. And so, yeah, I can't emphasize that enough, to be cognizant of the level of stress on the crews. What you're seeing in society, is only magnified within our own ranks.
So I think that was a good reminder. Target Solutions on the right-hand side, underneath all of the COVID information, the mental health resources have moved down, but they are still there. They should be in green, I think, on the bulletin board on the right side of Target. Also, everybody has Firestrong available to them out there too. They are also looking for their resources.
Okay. So here's another question about thinking about whether we go to category red. I think it's a real possibility. I hope and I pray that we don't, but I think it's a real possibility based on what we're seeing right now. I think we could go to category red here within a few weeks, and I don't think that's anywhere outside the realm of possibility. Baycare, HCA, and Bayfront have all slowed down, if not stopped, elective procedures in Pinellas County because of the strain on their systems. There are orders for additional nurses in the, hundreds, requested through state emergency management to come and help. And there are real discussions about field hospitals and things like that. So yeah, the potential for us to look a lot like New York City looked in a matter of a couple of weeks is real. I know of some hospitals over in on the other side of Florida down south where fully 50% of the patients in the hospital are COVID positive. Think about that for a second. Think about what that takes in terms of PPE and extra staffing and exhaustion. That is not easy. And one of my friends, I think I've mentioned before, my co-fellow from up in New York, she described it at a certain point as there's no such thing as a non-COVID patient anymore. They all have COVID. The MVC has COVID, the GSW has COVID, the stroke has COVID. And so if we get in that scenario, I mean, just think about how much more strained the healthcare system will be. So I do think that there's a very real possibility that we could go further into the pandemic plan, like towards a condition red before too long. All right. Chief Bessler says, who's our best contact about decision making? Your best contact on that is Department of Health Epidemiology. And if you don't have that number, Chief, I'll text it to you. But basically, that's where you're going to get the professional epidemiologist who's going to be able to do the contact tracing and lay out who has what level of exposure and what is an appropriate course of action for those each of those folks. So if you don't have that number, I will text it to you. All right, what else we got? Don't make me put on more music for Peggy. Peggy, you should email me a music file and then I'll play it during one of these. That way you can pick the music. Okay. Not seeing too many other questions. I know today is not the most cheery. Oh, I know one. One blood. One thing we need is convalescent plasma. And so if you are one of those people who have already had COVID and recovered, I would encourage you to consider donating blood. just go to the One Blood website, and there's instructions on the landing page for how to set up an appointment to donate plasma. So convalescent blood is potentially very, very helpful, but the hospitals are telling us that they have a shortage of it given the number of patients we have. Schools, yeah, schools is a concern. We're 3.5 weeks or something like that from schools opening. And I know there's a lot of work and thought going into how they're going to do that. But I'm not directly involved in that task force, thankfully. But yeah, I think it would be naive to think that we will not see some increase in cases as a result of schools reopening. No matter what mitigation strategies they decide. Do we know the average age of patients in the ICU? Hang on, let me look.
Mike McKnight, that's a good question. If we have a smaller size mask for pediatric patients on the ambulance.
Yeah. So I can tell you that we are 51% to 49% over 65, under 65 in the ICU, but that's all ICU patients, not specific to COVID patients. I can't give you the specific COVID number right now. I'm not sure if that was it was somebody from Clearwater Training. Okay. Child smaller size surgical masks for those potential patients. I don't know. That's a great question. Jasmine, did you say you had an answer to that or no? Oh, you got distracted. Does anybody who works at All Children's on the side or anything know the answer to that? I don't know.
About the masks?
Yeah.
I think that's a good question. I'll talk to David about that and see if we can get some smaller masks. I know they exist.
Okay, there you go. So somebody's asking for a little comment on percent positivity. And yeah, I can comment on that. Let me pull this back up. So here's our percent positivity is this green line. And you can see that a couple of weeks ago, we were down here in the neighborhood of 1%, 2%. And we have just blown through the roof to nearly 13%. Now we're down just a little bit this week to not quite 10%. I would urge a small note of caution on that because of the holiday weekend, which may have a little bump in our data still left over from July 4th. I would also note a little bit of caution in that decline in percent positivity as a result of the new Mahaffey testing site, which is testing a lot of asymptomatic people who didn't have to get referred by their doctor to go there. And so, like, for example, when they opened the Raymond James site in Tampa, they did see their percent positivity drop down just a little bit as a result of that less restrictive testing, where they were testing more asymptomatic people, not just symptomatic people. So I think overall, our percent positivity has skyrocketed over the last 3 or 4 weeks, well past the levels at which most folks would say that a lockdown, for lack of a better word, is warranted. And I know that there's been a lot of discussion about the percent positivity, but statewide, we're 15% positive, which is through the roof and not a good thing. And at 15% positivity for the testing, this thing is on fire. It's burning hot and embers are flying everywhere. So I hope that answers your question, Troy. There's a lot packed into percent positivity. It's a good number to watch, but you also have to kind of just look at trends in it, not just a point in time. I think it's important not to get caught in any single daily data point. You've got to look at the trend of the data. Bringing students back into the field, yeah, those discussions are underway. At some point, we need to remain operational and keep new folks in the pipeline as folks leave. So yeah, there is discussions about that. I think you will probably see students back on trucks before too long, simply out of necessity. But that still has some discussions to go between the colleges and the provider agencies. So I'm not sure you'll see it quite yet, but those discussions are underway because we have to figure out a way to keep medical education going, just like we have to figure out a way to keep medical school going, just like we have to figure out a way to keep kindergarten going. I mean, we can't imagine what would happen if we lost an entire year of education for an entire generation of kids. I mean, there's some real struggles there. So yeah, I think you will start to see students back in the field before too long. They'll obviously have to wear all the PPE and everything else. So I did not hear anything about Pasco's school date yet, Ken, so I don't know about that. Okay, airborne transmission. Yeah, so you're hearing a lot about airborne transmission. What to say about this? So this is a very complicated issue, very complicated, because like most things, it's not black and white. There's a lot of shades of gray. And the shades of gray go something like this. When you talk, sneeze, cough, or otherwise live, you emit particles as part of your respiration and all those other types of activities. And those particles come in a range of sizes, from the smallest ones, which are 1 or 2 microns, to the larger ones, which are 5 to 10 microns or even larger. And that's a continuum, it's a spectrum. When it's in the 5 to 10 micron range, we generally refer to that as droplet. When it's in the less than 5 micron, we generally refer to that as airborne. And so that's the historic framework that this goes in. And diseases that are considered airborne isolation are ones where you're more likely to have transmission based on those smaller particles that can float in the air longer. Droplets tend to, because of gravity, fall to the floor before too long, but aerosols will stay suspended in the air. So a good analogy I heard Dr. Osterholm say was, imagine the sun streaming through your window in your house, and you can see all those little particles of dust in that stream of sunlight. Those are like aerosols. They just float in the air. They don't sink down. They just float around for hours based on the small air currents in your room. So anything that can transmit viable virus on a particle that small that can remain in the air for that long is clearly much more difficult to deal with than something that only transmits based on the larger particles that fall to the floor faster. And maybe after a minute or two, most of the big particles are on the floor and you're not going to breathe them in anymore. Whereas the smaller particles would linger in the air for hours, 3-4 hours sometimes. And so the debate about what level of respiratory protection you need encompasses not just the size of the particle or the efficacy of the respirator, but how many particles there are, what size they are, how long they stay in the atmosphere, what the air currents in the location look like. So outside is obviously safer than inside, right? Because air is moving and the particles will be washed away. Inside, with high ventilation where the air in the room is being turned over 5 to 10 times per hour, is obviously much more safe than areas where you don't have that ventilation. And so it's the size of the particle, it's the physical characteristics of the location, and it's also the infectious dose of the virus itself. Because just because you get one virus of COVID in your lung doesn't mean you're going to get sick. There's some infectious dose that you have to get to. Think of it like a toxic dose for a medicine. A tiny little bit of it is probably not going to hurt you, but a big slug of it will actually make you sick. So in the same way for infections, you need an infectious dose. So you need a certain number of those virus particles to hit you in a certain time period. So there's a lot that goes into airborne versus droplet transmission. And it's complicated to the point where it's difficult for the folks who don't deal with it every day to understand. And it's very difficult for the public to make heads or tails out of things like, well, you told me the mask would work. What do you mean that mask isn't sufficient for this? Or what do you mean I still have to distance? Or maybe I shouldn't eat inside a restaurant. I thought the masks were working. And we all said we had to wear the masks, but what do you mean they're not working? So what I would tell you is it's not that cut and dry. Will a mask offer some protection? Yes. No matter what kind of mask it is, it's going to offer some protection. A fit tested N95 is clearly going to offer you more protection than a loose fitting surgical and, than a procedure mask. But none of them are 100% ever, right? And if you have a huge amount of virus in the air, like during an aerosolizing procedure, clearly the risk is higher regardless of what kind of mask you're wearing. And if you can do something to be in an environment where there are much fewer of those particles in the air, then the risk is less. So the point is that all these things are additive. Washing your hands, doing good hygiene, wearing your mask, avoiding enclosed places where virus might be in the air, staying away from people who are sneezing or coughing and generating lots of aerosols. All of these things are additive. None of them on their own will protect you. We need to do them all. Just like you wouldn't rely solely on your airbag in your car to protect you. You would also wear your seatbelt and you would also drive defensively. And just because you have an airbag doesn't mean you can drive like a maniac and not get hurt. Also doesn't mean, by the way, that somebody else won't drive like a maniac and hurt you. So hence being defensive and knowing what your risk is, being thoughtful about what you choose to expose yourself to. The bottom line is it's a respiratory virus. It's transmitted in the air primarily. And that means breathing air that other people have breathed out virus into is how it's transmitted. And so whatever you can do to minimize that exposure is to your benefit. And 6 feet is probably okay. 10 feet's better, right? 10 minutes inside is probably okay. 3 minutes inside is better. So do what you can do to minimize those risks. It's very, it's lots of shades of gray and it's a spectrum and there's no black and white simple answer. And that's part of the reason why we're struggling so much with this is because this is not stuff that's easy to understand and because we don't have consistent messaging coming from our leaders. All right, I'll get off that soapbox. Sorry. That's one we struggle with a lot. It really is. Okay, so what is the accuracy difference between the deep nasal swabs that DOH does versus the ones that you can order through places like LabCorp that only swab the inside? So all tests have performance characteristics that you need to be aware of when you make a decision off a test. So in medical school, Dr. Nassar, you want to just give us a quick explanation of positive predictive value, negative predictive value, sensitivity, specificity, and percent agreement? She's like, no, sure. I don't want to. So sensitivity, you'll see, don't worry, I'm just teasing. You don't have to. Just make sure I say it right. Okay, how about that? So sensitivity is how likely you are to pick up a positive. Specificity is how likely that positive is to be true. So if a test has a sensitivity of 80%, you should expect that 8 out of 10 positives will turn positive on the test, but 2 of them will turn negative. And if a test has a specificity of 90%, you should expect that 90% of the positives that you get on the test are true positives. And so basically, you want ideally a test with high sensitivity and high specificity to get an accurate and reliable test. And every test has different sensitivity and specificity numbers, and the technique you use to do some of these tests can affect those numbers. Unfortunately, you also have to factor in, when you're thinking about how to apply a test clinically, something called positive predictive value and negative predictive value. And there's where it gets complicated. The math is stuff that I want to forget from statistics class. But basically what it comes down to is your test performance does better if there are more cases out there in the environment, and it does worse if there are less cases in terms of your positive predictive value. So if you have a very low prevalence of disease, based upon the sensitivity and specificity of the test, a test is useful to you to say, yes, this is probably a case, more so if there's more cases in there, because the test will likely be right more of the time. And so when you practically apply sensitivity and specificity, there's also a calculation that goes in terms of how prevalent the disease is in your population. And so the math gets complicated and the concepts get complicated, and they're always tough to try and explain. But I would say just look up the test and find the sensitivity and specificity of it. See if they give you a positive predictive value, and compare that to other tests. I would say, on the whole, the nasal swab tests have very, very good specificity. Most of them are in the 98 to 99% specificity. The sensitivity is where it gets a little tougher. Some of them are in the 80% range. Some of them are closer to 90 or 95%. And so I don't know those specific tests, but I can tell you that you want to make sure you understand the performance of that test before you make a decision based upon it. I believe that in general, the ones that swab the nose have a slightly lower sensitivity than the deep nasal swabs, but are still reasonably well performing. But again, you'd have to look at the individual test to know. That was a long-winded explanation. And if Dr. Lozano is on here, he's probably going to tell me I explained it wrong, but we'll see at Journal Club later tonight. Okay, so Chief Bessler asks if we still don't recommend confirmation testing for asymptomatic employees. So Chief, you're going to have to expand upon that a little bit. Confirmation when, like where in the course of an asymptomatic employee, what would be the application of that? Ken says, oh, it's Polk County that delayed schools. Yes, the humidity in the air and the amount of moisture in the particles does impact how long they float around in the air. It can also impact how well the virus structure can stay intact and stay infectious. So there's a lot of factors in there as well, Dan. Yeah, that's a big component of it as well. So temperature and humidity of the air can affect the ability to spread as well. Rick says, can you touch up again on why you want goggles, face shields in the cab of the transport units? Yeah, so unless you're 100% confident that you are completely sealed off from that patient and nowhere where the air could move, you can have virus transmitted. This was proven very early on in the pandemic. You can have virus transmitted by landing on your mucous membranes, and that includes your conjunctiva around the eye. And so that's why eye protection. There was one estimate at one point that it was up to 10% of cases were transmitted by the conjunctiva of the eye. Now, obviously, a lot of that is probably rubbing the eye, but it makes it a lot harder to rub your eye if you're wearing goggles. Some of it is theoretically, though, virus particles settling directly on the mucous membranes of the eye. So that's why, Rick. No, I haven't heard anything, Michelle, about hyperbaric treatments. And there is, that's what we were talking about before with the hepatitis C drug that they use in Europe. There is a discovery or at least an initial set of data that there's a antiviral that was traditionally used for hepatitis C that may have very good effect for this. So that remains to be seen. Chief says, if an employee has COVID-19 contact but are asymptomatic, you previously said testing would not be very accurate. So testing would not be very helpful, I think is what I said, in terms of saying that that person doesn't necessarily need to take steps to prevent transmitting to other folks. Because we know we have asymptomatic transmission, we know that if you've been exposed, even if you're asymptomatic, you could theoretically be infected and transmitting that to other people. And so the purpose of testing somebody who's asymptomatic during their quarantine period, frankly, near the end of their quarantine period, would be to try to ensure that you weren't allowing an asymptomatic person back to work who could then potentially pass it to other people. So because you knew they had a high risk exposure, they went into quarantine. And before you released them from that quarantine, you wanted one test to make sure, because they were young and healthy, that they didn't get infected asymptomatically and then be able to pass it to other people. I think that's probably pretty much the only time that testing an asymptomatic person would be helpful for our purposes of return to work kind of stuff. Hopefully that answers your question. Simon says, any word on students riding? Can we ride if we are Sunstar employees without wearing our PPE? So I think we talked about that a minute ago. And stand by, it's coming, I believe, but I don't think all the details have been quite ironed out yet. Oh, there you go. Jeremy answered you already. Okay. All right, that's all I see in the comments so far. We'll give you guys just a minute or two for any other questions. And then it's 5 o'clock, so we'll try to wrap it up. Coffee time, Peggy says. Okay, here you go. Let's try this. I don't know what it is. Oh, no, that doesn't sound good at all. Okay, well, if nobody else has any other questions right now, I think we'll go ahead and wrap it up for this week. We'll continue to do these just as long as we need to. Any final comments, Dr. Smith?
Oh, just everybody stay safe out there.
Dr. Nassar?
Same thing, everyone stay safe.
Billy, nice. Yeah. outside. Okay, Training Bureau says, what would you think about youth groups meeting outside with masks 6 feet apart? Yeah, I think that would tick a couple of the boxes to make a safe type of thing. I just worry about compliance with that. And Billy, say hi to Bailey for me. Good kid. All right, with that, I think we will go ahead and sign off. So we will see you all next week. In the meantime, please be sure to email or Instagram any questions or anything else, okay? All right, thanks everybody.